Good evening and welcome to the Cure HHT webinar series. My name is Nicole Schaefer and I'm the Director of Professional and Medical Programs for Cure HHT. I want to welcome you to this evening's webinar, HHT Lung AVMs, a Tangled Web. A few reminders. Tonight's call is being recorded and will be posted on the Foundation's website. After tonight's call, you will receive an email with a short survey. Please complete this so that we can better serve you in the future. Except for the presenters, everyone's phone or microphones are muted during the webinar to help reduce the background noise. If you have any questions at any point, whether it's now or while the presenter is speaking, go ahead and type them into the gray panel on your screen. Your questions will come to me, and I will present them to the presenter on the second half of the call. We just ask that you try and keep your questions more generalized so the answers will benefit everyone. Now, it's my pleasure to introduce Dr. David Riggans. He graduated cum laude from Wake Forest University and received his medical degree from the Medical College of Georgia in Augusta. He subsequently completed an internship at the Atlanta Medical Center, a radiology residency at the University of Kansas Medical Center, and an interventional radiology fellowship at the MD Anderson Cancer Center in Houston, Texas. Dr. Riggans has been involved in the Augusta University HHT Center of Excellence since its inception in 2003 by providing consultation and treatment for pulmonary AVMs. I now pass tonight's program on to Dr. Riggans.
Hey, and thank you, Nicole, and thanks to the HHT Foundation for allowing me to present. I hope that I can provide some helpful information to everybody, and I appreciate all of you that are listening and trying to gain some information about your own care or your family's care. So I'll try to do the best I can to accomplish that. So again, I'm going to be presenting on the lung manifestations of HHT, the pulmonary AVMs. Okay, so first I just want to go through the anatomy, and this is anatomy of a normal lung where you've got the pulmonary arteries feeding blood into the smaller and smaller branches, which eventually branch into capillaries, and the gas exchange occurs here. And so in a normal lung, this is where the oxygen gets brought in from the lungs into the blood vessels and where the CO2 gets emitted back out and expelled from the airway. And then it travels back into the systemic circulation and goes throughout the rest of the body. So in a patient with HHT that has pulmonary AVMs, this capillary network gets replaced in some vessels, a minority of vessels, but in some vessels by just a straight open vessel. So the capillary network is essentially gone in some of the pulmonary artery branches, which allows for a series of problems to develop. It may start out small, but over time, because of the pressure that comes through the pulmonary artery, the vessel that's not really designed to accommodate higher pressure blood flow expands, and it gets larger and larger, and ultimately it turns into what we typically see as an AVM with an irregular, elongated, and enlarged shape. So let's go through a couple scenarios. In all patients, there is a propensity over time with certain different clinical problems where clots can develop in your legs. It's a fairly common problem, and it probably happens a lot more often than we realize. And in patients with normal pulmonary vasculature, if a clot from your leg breaks off and ultimately it ends up going through your heart, passing into your lungs, the lungs in that situation serve as a sieve or a filter, and it actually traps the clot because it passes into these smaller branches and it can't go any further. That's not necessarily a good thing because we don't really want clots in our lungs, but typically our bodies have the capacity to be able to accommodate those clots and to break them down over time. Now take that same scenario in a patient that's got HHT and pulmonary AVMs, and the clot passes through the AVM. There's nothing to trap it. And so it ends up on the other side. And once it ends up on the other side, it goes back through the heart and it can get distributed to anywhere in the body. The most concerning of which would be the brain. And so when it ends up there, you can end up with a stroke or a transient ischemic attack, a brain abscess, seizures. If it ends up in the heart, it can cause a heart attack. It can really go anywhere, to your kidneys, to your legs. And so that's one problem that can develop with the pulmonary AVMs. Now let's consider the hemodynamics. Blood flow is going to preferentially take the path of least resistance, and a capillary bed provides resistance because the blood's got to squeeze through these smaller branches and it slows everything down. Now, when the blood flow passes through an AVM, it doesn't have to slow down, and so the blood flow is going to preferentially go through the largest vessel, which is the AVM. The problem is that the AVM, as I mentioned before, there's no gas exchange occurring here. All the gas exchange occurs here, and so when the CO2 in the blood goes through here, it's not getting released. And the lungs aren't populating these blood cells with oxygen because there's no connection to the capillary network. And so the heart is wasting a lot of energy pumping the blood flow through this AVM for really no good. And so this unoxygenated blood passes out through the body. It doesn't really do much good. It comes back and it's just recirculating through this AVM. So the heart's having to work extra. You're potentially having to breathe a little bit harder if you're exerting yourself because there's a decreased efficiency of your oxygenation system in your lungs. And ultimately that can result in exercise intolerance. You can't exercise to the same degree that a normal person could, or even walking up and down the stairs might be challenging. You might have to carry around an oxygen tank. Ultimately, if the heart's having to pump too hard, it can lead to heart failure. The third thing that can happen is, and this is particularly common, not common, but it's pregnant women are more prone to this situation where during the pregnancy, there's more and more blood that develops to help with the growth and development of the fetus. And during the third trimester, the blood volume can increase by up to 50% over the female's regular blood volume. And so as there's more blood passing through the body, there's more pressure on the blood vessel walls, and this particularly weak vessel where the AVM is located is prone to expansion. And over time, there's a chance that it can actually expand to the point where it'll rupture, which can be deadly both for the mother and for the child. So this is a situation that's really risky that we try to avoid. So the clinical manifestations are in the brain, stroke or TIA, brain abscess, seizures, headaches, and heart. It can lead to a heart attack or heart failure. And in the lungs, shortness of breath, exercise intolerance. Actually, they can cough up blood, and you can get a rupture of the sac during pregnancy. So I want to talk a little bit about screening. Most of the patients that come to our center go through a routine screening process where they get genetic testing. They typically get a bubble echo. And the bubble echo is kind of one of the first lines of the testing process. The way it works is there is an injection of agitated saline, which we basically just agitate saline in a syringe so that there's microbubbles or tiny little bubbles within the saline. And we inject that through a peripheral IV in the arm. And as those bubbles travel up through the bloodstream in the arm, we're imaging over the heart with an ultrasound unit. And the goal is to watch those bubbles pass through the right side of the heart and then see, as they pass through the lungs, we see if they end up back in the left side of the heart where they should not be. So you expect them to be in the right side of the heart, but not in the left side of the heart, because typically those bubbles would get trapped in the capillary network of a normal patient's lungs. So, and that situation is graded. So if it's a grade 0, then there are no bubbles in the left side of the heart, and so it indicates that there's no shunt or no AVM. As you get to grade 1, there's more bubbles that pass through, or there are some bubbles that pass through, indicating some degree of an AVM. And as it gets higher to a 2 or 3, it means that there are potentially larger shunts there. So the contrast echo or the bubble echo serves as the first line of testing, and depending on how many bubbles pass through, if there are not many or none, then you don't do anything, and they just get that bubble echo repeated 5 years later. However, if it's a larger shunt, grade 2 or 3, then they get on to where they get a CT scan of their chest, anticipating that we're going to find some pulmonary AVMs. And then on that CT scan, we look to see if we find them. And if we do, we assess those based on their feeding artery size. So the artery that leads up to the AVM sac is called the feeding artery. And the diameter of that artery is important. So a small feeding artery that's less than 2 millimeters in diameter, we typically don't worry about. And so we don't treat the patient, and then they come back in 5 years and they repeat their CT scan at that time. If it's larger than 3 millimeters in size, we definitely treat them. Then there's a gray area where it's between 2 and 3 millimeters in size. And in that situation, we have a conversation with the patient. We consider the number of AVMs that are there, the degree of the bubble echo. If it's a grade 3 echo, it's more severe. If there are multiple AVMs, we typically are going to lean towards embolizing them. However, if it's just a single AVM, or it's a lower grade bubble echo where there are not that many bubbles passing through, then we may not embolize them. So let's look at some images of the bubble echo so you'll understand a little bit better about what that involves. So again, let's pretend the patient's arm is out here. We're injecting this agitated saline with the bubbles, and it passes up the arm, and we're imaging over the heart. So this image of the heart, it shows the left atrium, and this is actually kind of the heart upside down. So if you imagine the heart flipped, the atrium typically are at the top of the heart, but with the way this imaging occurs, it looks like it's at the bottom. So left atrium, left ventricle, right atrium, right ventricle. So when the bubbles come in, they come in to the right atrium, right ventricle, then they shoot out, go through the lungs, come back. Well, they shouldn't come back. In a normal patient, they should get trapped in the lungs. In a patient who's got AVMs, some of those bubbles are going to get through to the left atrium, left ventricle, and that's what we want to watch. So in this situation, we're looking at the left heart. Here's the left atrium, left ventricle. And in this particular case, there are no bubbles in here. So this patient does not have a shunt, or they don't have an AVM. It's a grade 0. Now, these little white dots are the bubbles. That's what a tiny bubble looks like on an ultrasound. And there are bubbles present in the atrium, and there are bubbles present in the ventricle. There are not many. If it's less than 30 on a single image like this one, then that's considered a grade 1. If there are more, then you have a grade 2. This is a grade 3, and these are just, hundreds or thousands of little bubbles are all in here. And so that's a grade 3. That indicates either a really large AVM or a bunch of medium-sized AVMs. There's a lot of shunting going on through the lungs, which is abnormal. So this is concerning. And grade 2 is concerning. So now we're back here with this chart again. So at this point, we've definitely got a grade, if it's one of the latter ones, we've got a grade 2 or a grade 3, and then we go to the contrast CT and through the rest of this tree here. That's in adults, 16 years or older. This is the typical pathway that we follow. In children less than 16 years of age, it's a little bit different. So we basically look at their symptoms if they have shortness of breath, or if they're coughing up blood. That's important to know. Or we also look at their oxygen saturation, which is a little measuring device we put on your finger, and it determines what the oxygen level in your blood is. So if their oxygen level is 96% or greater, which is essentially normal, we don't do anything, and we bring them back in 5 years. If they aren't having any symptoms, none, we bring them back in 5 years. However, if they are short of breath or if they're coughing up blood, then we do a contrast echo. If their oxygen level is less than 96%, which is abnormal, we do a contrast echo. And then that takes us back up here to the adult decision tree, and we go from there. Some patients come to us from outside hospitals where, for one reason or another, they've already had a CT scan of their chest. In that case, they've already been discovered to have an AVM or something that looks similar to an AVM, in which case we may not proceed with a bubble echo. They will come directly to me for an embolization. In some situations, the CT scan may not be definitive. It looks a little bit abnormal, but we're not 100% certain if it's an AVM, in which case we would get an echo to confirm that there's actually a shunt present, that we see the bubbles passing through the lungs like it shouldn't be happening. And if that's the case, if there is shunting going on and the suspicious finding on the CT scan, then they'll come to me and I'll embolize them. So this is a picture, several images of a CT scan with AVM. So these are normal branches here. All these little guys are normal branches. This is one slice. It's like you take a loaf of bread and you cut one slice out of it. This is what you're looking at. This area here, this is a really large artery feeding an AVM sac. And this is the artery that we measure the diameter of. So when I was referring to a feeding artery before, this is what I'm referring to. It's the diameter of this vessel right here. We've got another AVM right here. Here's another AVM. And again, all these branches are normal. This is what the lung should look like throughout the entire lung. This is not normal. All right, so on the CT chest, you know, when I'm looking at that prior to embolizing, because once we've done the CT chest, it's important to look at the CT, and there's a lot of information that can be gathered from that, in addition to identifying the AVMs. We can look at the size of the AVM, the diameter of the feeding artery, the anatomy of the pulmonary artery leading up to that point, because that's important, because I've got to get there somehow, and plan my approach. So there's a lot of information that I know just from looking at the CT scan before I ever actually talk to the patient and start the procedure. I just want to go back briefly and talk about the history of the treatment. It used to be that these were dealt with surgically. So the patient would have a big, you know, incision on their side of their chest opened, lung exposed, remove a section of the lung, and close everything back up. So, you know, very invasive, a lot of risk, long recovery period. And then people started treating these the way we're treating them now, where we're going in there with a catheter through a tiny little needle poke, basically, and embolizing the vessels leading up to the AVM. It's a same-day procedure. It's an outpatient procedure. And in 1997, they started coming out with information that suggested that it was actually just as effective, if not more, well, I guess it can be more effective because, anyway, it's just as effective and significantly less risky with a faster recovery period than the surgery was. And so at this point, it essentially rendered the surgical therapy obsolete and people were getting treated this way. So the way we do this is we get access into the femoral vein, which runs over the right hip. Well, it runs over both hips, but I typically use the right side. And from that location, that vein connects through the heart into the pulmonary arteries where we have to work. And we get up there using these special catheters, which are essentially long tubes, which we can direct specifically up into the branches of the pulmonary artery. So once we're up in the pulmonary artery, we do the pulmonary arteriogram. We basically inject contrast into one lung or the other. The contrast is what allows us to see the arteries. So here's one of these catheters. The other end of this catheter is in my hand outside the patient's body. The catheter passes up through the heart, which is right here, and out into the right pulmonary artery. It's split, like this is the patient's right side, the left side is over here. And you inject contrast, which is this black material, and it just flows out with the blood supply out into the branches of the pulmonary artery. And basically this looks essentially like a tree in winter. So if you imagine that pretty much all the leaves have fallen off the tree, you've got the tree trunk and the branches, smaller and smaller branches. These are all the normal branches. This is what you would expect in winter or in fall. There are a few areas which still have some leaf clumps attached, and those are abnormal. Those are the things we have to worry about. So let's get back down to the regular orientation, and let's follow this thing out. As the contrast continues to fill, we see these things represented a lot better, and even some smaller things we might not have noticed before starting to show up. These are all abnormal. There are about 7 that I can count right here, and those all need to be dealt with. And then we just watch the blood pass on through. So once we've gotten past that general diagnostic arteriogram of the lung, now we have to get specifically into these little branches that supply these. We have to get out into this branch. We have to get into this branch. And we do that with a different type of catheter. There are all sorts of different catheters and shapes that we can use to get out there. But once we get out there, then we have to evaluate the sac, the feeding artery. We may do different views. We can rotate our camera around the patient so we can get it from different angles and decide which angle gives us the most information, because we want to figure out the size of the feeding artery so we can pick our embolic device properly. We get a lot of information from these images. Once we've figured out the anatomy and we're comfortable with moving ahead, then there are a number of different devices we use to block the flow. And that's the goal, is to shut the flow down so that the sac no longer fills. We want to block, there should be no contrast getting into the sac by the time I'm done. And we want to block it right here. So coils are about the oldest and most commonly used device. It's been around for the longest period of time of the currently available devices. There were others, but they're no longer available for various reasons. But anyway, so this is the coil. It starts out as a straight line when we're introducing it into the catheter, but when it comes out into the pulmonary artery, it forms a loop like a spring. And we just pack a bunch of these in there until there's no more flow in the pulmonary artery. So the way this works is we take this coil, which starts out in a straight introducer device. This is the catheter. So I've got this end in my hand, this end is in the pulmonary artery. And we introduce that coil into this catheter. And then behind that coil, we have a wire, which we use to push the coil. And as the coil comes out the other end of the catheter, it automatically starts to form into that spring-like shape. So we push the wire pushes the coil, and the coil starts forming this fluid. And once we push the wire all the way through, the coil is all the way out into the pulmonary artery. There are some coils, most of the ones that we use, we just push out like that. There are some coils where we can actually deploy them. So once it's out in the artery, we can see if we like it or not. If we don't like it, we can actually pull it back in. If we do like it, we can unscrew this little device and release it. These are used in slightly more risky situations where you might not feel 100% confident that the vessel is going to be safe. So that's out there and available. There are other slightly newer devices. These are probably a decade or more old, but relatively new compared to coils. And it's called an Amplatzer plug. It's basically a cylindrical device that also is deployed through a catheter that starts out very small, and then once it's released into the artery, it expands to fill the space, and then it essentially adheres or presses out against the wall of the artery and holds in place. And ultimately, these holes are so small, it really doesn't allow much blood flow through, and over the course of a few minutes, this will shut the blood vessel down. The nice thing about this is that if you don't, and then you unscrew it. So once you're happy with the way it's positioned and everything is occluded, then you unscrew this little device and you pull out the wire, and then it's released. So these are pretty handy. There are a number of different iterations. This was the original Amplatzer 1 device. It's just a basic straight, it's a cylinder. Then there was an Amplatzer 2 device, which has the same kind of cylinder here in the middle, but then it's got a pancake on either side. And the pancake has 2 occlusive surfaces. The cylinder has 2 occlusive surfaces, and the other pancake has 2. So there's actually 6 occlusive surfaces on this device. It helped to really shut things down. This is the newest device, the Amplatzer 4, and it's got a Hershey's Kiss design on either side of these things, and it's essentially got 4 occlusive surfaces to it. So they've gotten better over time. When you look down the barrel of these things, again, it's just a cylinder, and it's got a round appearance if you're looking down the barrel of the device. From the side, the Amplatzer 2 looks like this, the Amplatzer 4 essentially looks like that. The goal with these occlusion devices is you want a size that's slightly larger than the size of the vessel diameter, because you don't want it flowing downstream. If you put in too small of a diameter device, it's just going to flow downstream. It's going to cause all kinds of problems. So you want a size that's slightly larger than the artery diameter. So when it goes in there, the Amplatzer device that would typically look like this, unconstrained, will be stretched out, elongated, but slightly narrower. And the same with this device, the Amplatzer 4. So that's the way it might look when it's in the body. Then there's one other device that's relatively new, maybe 5 years old, and it's a microvascular plug. These can go in through microcatheters, which are really, really tall, really, really small diameter catheters, and actually have this outer PTFE or fabric coating, which helps to block the blood flow. These are really handy. And then lastly, there's a microcatheter that's got a little balloon tip on it, so when you get the catheter positioned in the right place, you blow the balloon up and it holds this catheter in place. You can deploy your coils through that in other slightly precarious situations. So what size AVMs do we treat? We went through this a little bit earlier to some degree, but we typically know that we're going to treat 3 millimeters or larger. with experience and knowledge, we've gotten to the point where we can treat them at 2 to 3 millimeters or larger now. So we're getting into smaller and smaller feeding arteries. Why do we treat the smaller ones? It's not as much stress on the heart because it's a small AVM. It's less risk of rupture during pregnancy. There's less shortness of breath because the degree of blood shunting is not as much. So why do we treat it? They shouldn't be as threatening. The reason why is because even if they're small, they can still result in a stroke because tiny little bits of blood clot can still get through there, or a transient ischemic attack. Brain abscesses can still happen in patients with very small AVMs. So that's why we've gotten to the point where we even treat these smaller ones. The technical goals during the embolization process is to get as close to the sac as possible when we're embolizing it, make sure we choose the right size embolization device, and we want to pack things as tightly as possible so there's no room for flow to go through there. And again, as I mentioned before, you don't want to see any contrast getting beyond these occlusion devices into the sac. Once you embolize the sac, then you want to make sure it's not feeding from the second branch. So just because you embolize one branch doesn't mean you're done. You have to check and make sure there's not a second branch and embolize that one if you find one. And that's what can happen here. So here are simple AVMs where there's essentially one branch going into the sac and coming out the other side. In this situation, if you block this one, but you don't check this one, you're not going to have very good results because this whole thing is going to be filling from this other branch. So it's important to check and make sure you embolize all the branches feeding the sac. So here's one example. The catheter is out in the periphery. This is the feeding artery. Here's the sac. Here's the draining vein coming out the other side. So we pack the coils right next to the sac as best as possible. And then once we're done, we check to make sure that there's no flow through there and nothing else is filling it from any other angle. Here's another example. Catheter's down in the distal aspect of the feeding artery. Here's the sac, and here's the draining vein. And we pack the coils as tightly as possible so there's no daylight between any of these loops. And we follow it up and check. And these are all little branches coming off, and none of them are going down to the sac, which is right here. So we're done. Here's another check to make sure this is just a normal branch that's near some of these other AVMs, and there's no flow feeding the sac of the other adjacent AVMs. So we're okay here. Okay, let's see. So why are we so interested in all of this? Why do we care about this stuff? Why are you guys listening to me talk? Why am I talking to you? So the reason why is because as we gain more knowledge about the situation, we can improve our ability to take care of ourselves. If we've got family members that we care about, we want to make sure that we are taking care of them. You love them. This is my family. This is my daughter, my wife. If they're in this situation, I would want to educate myself as best as possible to be able to make sure that I can take care of them and get them to the right place. So that's why we're all here. I want to go through one case here. This is a CT scan that shows a small AVM. This is not normal here. Here's the angiogram. So we've gotten to the pulmonary artery stage. And here's the artery feeding into it. Here's the sac. And here I've gotten the catheter out into the feeding artery. So actually this is the sac, this is the draining vein. And here the catheter is in the feeding artery. Here's the sac, here's the draining vein. And what I've done is I've used the Implanter 4 device here. And these markers on either end of this device are these markers right here. This is a magged up view of this section right here. And these are the normal branches that are back here. And the sac, which is right here, is no longer filling. So this was a successful treatment. There's also the opportunity to embolize the sac. I don't do this very often, but you can actually get the catheter out into the sac itself. So here's the sac, feeding artery, and here's an example of the coils filling this sac right here. And the feeding artery now, after it's been coiled, here are the coils, and there's the AVM is no longer filling. So treatment complications, what can happen? Air bubbles can get through the feeding artery in the sac. So we have special precautions we take during the procedure to make sure no air gets introduced into the patient. The device, if you don't size it properly and you put a coil in there or a plug that's not the right size, if it's too small, that can go through the AVM and cause problems. A clot. Clots can sometimes form on the catheter of the devices during the procedure, so we heparinize the patient's blood, which thins it to minimize the risk of clot developing during the procedure. So we take precautions to prevent this. When we're embolizing the AVM, the feeding artery, there are sometimes small adjacent arteries which also get blocked inadvertently, it happens. And it's going to happen pretty much in every case to some degree with tiny little branches. They're essentially insignificant. But the problem is it can cause pain because it's a normal branch, it's getting blocked and blood flow to that area of the lung is changing, and sometimes it causes inflammation. So it is possible to, and very common to block small adjacent branches, but the pain is short-lived. If it happens, it usually doesn't happen. If it does, it's short-lived, and it can be treated by anti-inflammatories if it occurs. Usually 3 to 4 days later, it's gone. And that's what this is, pleurisy. If you use too much contrast to visualize arteries, it can cause kidney failure. Down the road, sometimes these AVMs can recanalize or get flow back through them again. Even if it was embolized successfully, sometimes they can get flow back through them again. Patients can bleed during the procedure, either from the groin access, from the AVM sac if it were to rupture. Patients can have nosebleeds during the procedure. Infection. We don't ever treat patients that have an active infection. So if you come to me and you're infected, you've got a pneumonia or you've got a cold of some sort, depending on the degree, we may not treat you that day. So in follow-up, we typically follow them up with a contrast echo, the same as what we started with, to make sure that any grade, if there's a high grade shunt, it's no longer there. And we'll typically get a CT chest to make sure that the sac is decreased in size, typically by greater than 70%. We want that sac to shrink. And we don't want any contrast to be in the sac anymore. We want the contrast to stop where the embolic products are, not go any further. And on the contrast echo, we want to see that the shunt grade is dropped. If it was a 3 to start out with, we'd like to see it a 0, but even a 1 would be fine. So in the follow-up, we treat the AVM. 6 months later, we get the contrast CT and the echo. If the CT shows that we did not succeed and there's still contrast in the sac, getting past the coils or the embolic products, then we come back and we embolize them a second time. And again, we repeat it until we're happy and we've had success. There's no more, the CT looks good. Then we look at the shunt, at the echo, to see if there's a shunt or not. If the echo shows a grade 1 or no shunt, then we bring the patient back in 3 years and we just follow them with the echo. If the echo is a grade 2 or 3, the CT showed that we're successful, but the echo still shows a significant shunt, then we'll still wait 3 years, but we'll bring him back and we'll do a CT the next time around. So this pathway, we get an echo, this pathway, we get a CT. All right, so here's an image before when the sac is still open, and then here's 20 weeks later, the sac is essentially gone. So over time, the sac shrinks and goes away. The same thing here. Here's a sac. Years later, you can't even really identify it anymore. So what if the sac doesn't shrink enough? It can recanalize, meaning flow goes through the coils into the sac. It can bypass through another branch that wasn't treated, or sometimes an adjacent normal branch might still provide capillary flow through the veins and into the sac. So there's several different ways that the sac can still opacify, and it's important to distinguish between those because some of them require treatment or retreatment, some of them don't. A study done at UT Southwestern showed that there is persistence oftentimes with the different embolic products, even amongst experienced operators. Coils are generally the least effective. The inputs are plugged with coils, or better, and the microvascular plug, which has that PTFE fabric coating on it, are the most effective. Another interesting study showed that, and this is way back when they were first doing these things, but for the first years that this one center was learning how to do these, they had a 13% recurrence rate. After they gained experience, the recurrence rate essentially dropped to half. If they gained further experience, it dropped almost in half again. So the important take home there is that you want to go to a place that's done a lot of these. There are a lot of people that treat AVMs that may not see them very often, but if you're going to an HHT center, you're going to be dealing with people that treat these all the time. They probably got hundreds or thousands of these under their belt, and you're going to be more in this category if you go to those locations. So let's look at a couple examples. Sac persistence after treatment. So here's one where there was a treatment, and oftentimes I'll get these patients. They'll be treated somewhere else, and then they come to us because it wasn't effective. And so in this case, there are coils here, and there's a draining vein here that still has contrast in it. So maybe at one time, the coils were demonstrating occlusion when they first did the procedure, but now they've recanalized. So now we go in there, and here's the arteriogram, here are the coils, and here's the draining vein. We shouldn't see this. Here's a sac. So then my job is then to go down in there and try to add additional products, maybe a little bit tighter than they were before, or different products, and try and shut that thing down. So here we've occluded the flow, and there's no more filling of the sac. Here's another example. Coils, coils, and here's on the CT scan, we can see this draining vein. And on the angiogram, when I've got the patient, I'm doing the procedure, you can see flow going right through these coils. And here's the draining vein. So this is an implanter 2 device that's here, and we've shut down the blood supply, and there's no more filling of that sac for draining vein. Here's another example. I mentioned before about how the goal is to get down as closely as you can to the sac in the feeding artery. In this case, on the CT scan, you can see the coils are way back here, and the feeding artery is way down here, the sac down here. And here's an exact same image on the angiogram, and here's the pack of coils, and here's the flow going right down into the sac, right through all this stuff. They've done a nice job of putting a lot of coils in here, but it ultimately wasn't effective. It might have been at the time, but these things can recanalize. And this isn't really an ideal location for the coils anyway. The coils should be down here. So this is where you want to coil this, not way back here. So the next problem is that all these arteries, which now have blood flow and are normal arteries that are doing the patient some good, are in jeopardy. I tried to get through all this stuff to see if I could get down to this point, but sometimes it's really hard to navigate through this jungle of coils. So I wasn't able to succeed, and I had to block it back here, essentially back at this proximal aspect of the coils. And what's missing? All of these vessels that were filling before are now missing. We've shut down the AVM, and that's the important part, and that's the goal. And it's okay to sacrifice these vessels, but it would be better if we didn't have to do that and we could get down here and embolize it here the first time. Or if on the second time I could have gotten through here and blocked it. The ideal location is here, and this is what happens if you don't do the ideal location when you're treating the patient. Here's another example of embolizing too far proximal. So in this situation, and this is not my case, this is actually one I got out of an article, but it illustrates things that I've seen numerous times. The artery comes down here. Here's the sac, and this is the draining vein. These coils shouldn't be here, they should be down here. They should be down on the distal aspect of the artery, not the proximal side. And they're not even very tightly packed. I mean, you can see all kinds of stuff through these coils. So the blood flow is just blasting right through here, going down and still filling the sac and the draining vein. So again, the idea here is to get through these. And actually, and the other thing, so they went into the next branch over, another artery, to see what's happening. And this is interesting because here's another branch that's essentially almost normal. There's no large AVM, but there are these little branches that are passing out of that artery into the distal aspect of the artery that we just looked at. And what's filling as the contrast goes down, here's the sac. So we're not even injecting the main artery that's feeding the sac, we're injecting the next one over, its neighbor. And it's shooting these little branches across, which are going into the distal aspect of this artery and filling the sac. This is another problem that happens when you've embolized too far proximally. If you embolize down here, this wouldn't occur. So what did they do? They got a microcatheter through this coil, which wouldn't be all that difficult because it's mostly space anyway. The microcatheter goes down and they're embolizing it down here where it should have been embolized the first time. And that's what this is, a tightly packed nest of coils. It's doing its job. They actually packed a few more up here amongst this other one. And now they're back down in this neighboring vessel, injecting that. And what's happening, there's still branches coming across and they're filling this section of the artery. But what's not filling? The sac. The sac doesn't show up because this section of the coils is doing what it's supposed to do, and it's blocking the blood flow. So again, this is why you want to get down into the right position before you start dropping coils in there, not too far back. And real quickly, I'm getting a little bit close to the end of where I wanted to be with this talk. So I'm going to pass through. There's some benefit basically to using an Amplatzer plug plus the coils. And here's an example of some coils and a feeding artery on the CT scan that's still filling. And this isn't one that was previously treated. This is during a process of me treating multiple AVMs. This is one that has not been yet treated. And I've gotten through the artery, and I'm dropping an Amplatzer plug, which is indicated by these two markers. And then behind that, I'm putting coils. There are studies that have shown that combining these devices, putting a plug and coils, is more effective than either of these alone. So in a lot of situations, I'll actually use both products to try to do the best we can to prevent this thing from recanalizing or reperfusing. And then here's a last complex AVM that's of a teenager that we've treated several times. He's got an AVM that has multiple feeders. It's a really complex and difficult to treat AVM in his left upper lobe. And these are just CT scans through that area showing all, this is abnormal, these are all abnormal, and here's a series of abnormal blood vessels, all of these. Here's what it looks like on the angiogram, and here are just some examples of some of these abnormal blood vessels. We treated some of these before, or this might have been early during the same procedure. Abnormal, all of this stuff. So when, and these in particular, this is later in the arteriogram, but this branch is abnormal. All these green arrows point to the abnormal blood vessels supplying this complex nest of AVMs. So what we have to do is just go through and shut down each of these individually. Just take them one by one and try to block the blood supply to all these branches and check and see, okay, what else is filling? Block some more, check again. Block some more, and eventually you end up with a whole, essentially I've eliminated the blood supply to this whole section of the lung, which is still very small. Globally speaking, he's still got, 95% of his lung is perfusing normally, but we've essentially blocked this entire section of his lung. Even blocking as much as we did here, if this patient were to go to surgery using the old original style of dealing with this, it would have removed 2 or 3 times the amount of lung tissue that I blocked by treating it this way. So again, we can be much more selective, much more precise, and take care of the patients much faster with a quicker recovery period and than we used to be able to do years ago. And that's it. So essentially got, I guess, about 15 minutes maybe for questions. Nicole, I'll turn it back over to you.
Great. Thank you so much, Dr. Riggans. That was an incredibly thorough overview of the screening and treatment protocols for AVMs in the lungs. And before we move on to our Q&A, I just want to remind everybody that on your control panel, there is a gray area for handouts. And we did include the lung AVM checklist from the current clinical guidelines. But I do want you to know that it's been 10 years since the clinical guidelines were originally developed. So CURE HHT is hosting and funding a clinical guidelines conference on November 9th and 10th of this year in Toronto, Canada, with HHT experts from around the world and some patients, HHT patients. And once these new guidelines are published, which will probably be in about 6 or 8 months, we will be sharing that with the HHT community. So our first question relates back to imaging and how often should imaging be done if someone has small AVMs? Like, what would the recommendation be for watching them grow?
So, and again, it's partly dependent on the degree of shunting that's present on the echo, but typically they'll come back either in 3 years or 5 years, depending on their size and the degree of shunting.
Okay. And when you do the echo bubble, someone is asking, does it matter which arm is injected for the test?
No.
Okay. And to embolize, do you need to use the .02 filter when you're doing IVs? Or are you just, is the recommendation now just to keep air out of the line?
We always use a filter 100% of the time. And I think that's pretty standard. I think that's what the centers essentially all follow. And that's one aspect of preventing air from getting in there. The other aspect, so that keeps the line clear when the IV, when the nurse is putting medications through the IV. Then on my side of things during the procedure, when I'm introducing the coils or the implants or devices or doing injections, I have to be real cognizant that there's no air bubbles in my syringes or my devices. So there's a whole other series of things that I do during the procedure to help prevent air from getting introduced.
Okay. So someone is asking what the normal oxygen level is in adults.
96 or above.
96
so when I test my own, it's usually 97 to 99.
Okay. And regarding the feeding artery, a question is, why do we wait until the feeding artery is greater than 2 to 3 millimeters to embolize, especially in young kids? Their feeling is that, are we just waiting for something bad to happen?
Yeah, and I understand that thought process. The trick is, so let's take an adult, which is the easier scenario to deal with. If there are small branches in there, there are risks with the procedure itself. So if on the CT scan you see that they're really, really minute AVMs, you don't want to put somebody through a procedure, even though it's, you know, a lot less risky than surgery. It's still risky, and you don't want to put somebody through that if the risk is minimal. And so the risk is felt to be minimal with those smaller AVMs based on the studies that we've done up until this point. The other thing is, when we block the small AVMs, you're essentially blocking more small normal branches too. As I mentioned during the talk, you're always going to block a couple tiny little normal branches, even with the larger AVMs, because there are normal branches that go right down to the base of the feeding artery. So if you're treating a small AVM with only minimal upside, and you're also blocking tiny little normal branches in the process, the downside might kind of outweigh the upside. So that's why, you know, in an adult. In a child, it's a little bit more complicated, and there's still a lot of people looking into this and trying to research the best methods. The interesting thing about the developing lung is sometimes you can block an AVM perfectly, and there's no other blood vessels feeding it. But because the child is still developing and there's still new lung tissue being developed and growth occurring, that sometimes these AVMs have an uncanny way of getting new blood vessels supplying the same sac. And so you kind of end up chasing your tail. You end up blocking a bunch of branches, one after the other, and bringing the patient back for multiple treatments, trying to shut all these things down. And we've gotten to the point now where enough people have experienced that with enough different patients that some people have gotten to the point now where they just, go to surgery and they remove that section of the lung. So it's just a one and done situation. But kids are more complicated. So, but in general, those are the reasons why we have that approach at this time. And we've gotten to the point where we treat smaller and smaller AVMs, but there are some downsides to treating AVMs of that small size.
Okay, great, thank you. This next question is more of a confirmation. Is they just wanted to make sure that once a bubble echo is positive and a CT shows PAVMs, they just want to confirm that no further echo bubbles are needed. Is that correct, or would you still do echo bubble at some other point?
So I assume that the echo and the CT show indications to treat the AVMs, or not necessarily?
That they did not say.
Okay.
Well, actually, no, they did say follow-up is by CT monitoring every 5 years, measuring feeding arteries to determine if treatment is necessary.
Yeah, so in that situation, it was probably a high-grade bubble echo, and the CT showed AVMs that were essentially too small to treat. You know, they're probably in the 2 millimeter or less range. And in that situation, that's when we bring them back for a CT scan only. We know they've got AVMs. So the echo is going to be of really no benefit. We know there's going to be a shunt because we know they're AVMs because the CT showed that to us. So at that point, all we really care about is the size of the feeding artery. And so that's why if we determine with the first CT scan that the arteries are small enough to not warrant treatment, then we just want to wait 5 years to see if over time they grow, which sometimes happens. And so if they grow and the less than 2 millimeter diameter artery now has grown to 3 or 4 or whatever, then they fall into the category of, okay, we want to treat this now. And so then we treat them. So yeah, you don't, once you've determined a high grade echo and the presence of AVMs on the CT scan, you just follow with the CT.
Okay. Are there any medications that would limit someone's ability to have a lung AVM embolized, for instance, like Xarelto for DVTs?
The last part you said was jumbled a little bit.
Oh, sorry. Are there any medications that would limit someone's ability to have a lung AVM embolized? And the example is Xarelto for DVTs.
Yes. So we'd like patients to be off all blood thinners and aspirin, Plavix, anything that's going to limit platelet function or, you know, cause the blood to be thinner and not clot as well. We stop those before the procedure in varying lengths of time, you know, 2 days for some, a week for some. But yeah, all those things increase the risks during the procedure. So we have patients stop those. Now, that being said, during the procedure, we put them on heparin, which is a blood thinner. But we can turn the heparin off and the effects of that go away, you know, in short order. And we don't want to have patient on Plavix or Xarelto or any of these other things and also be putting them on heparin during the procedure because the risks would just compound at that point. So yeah, we do take patients off all of those blood thinning devices prior to blood thinning medications prior to the treatment.
Okay, great. Can you also just reiterate what the monitoring schedule might be for children? Do you do annual chest x-rays, or how often do you monitor kids since they're growing?
Well, that goes back to the chart that I showed with the kids which are under 16 years of age, and it depends on their symptoms. You know, are they having shortness of breath or coughing up blood or not, and what's their oxygen saturation level? And then if they have a bubble echo, is it a high-grade bubble echo that shows a lot of bubbles passing through or not? And so, you know, if they've determined that they don't need to be treated at this time based on all of that information, then, you know, we bring them back every 3 years and repeat those studies or that evaluation.
Okay.
I do want to go back to the last answer that I gave regarding the blood thinners. Being on a blood thinner doesn't permanently prevent you from getting treatment. It just means that we have to stop that some period of time, up to a week prior to the treatment. In some patients where they've just had a cardiac stent placed recently and the cardiologist said they need to be on these blood thinners for 3 months, you know, to make sure that the stent doesn't reocclude. And there are some scenarios where you have to wait and the patient has to be on the blood thinner for some period of time. But ultimately, the situation always resolves and they can be taken off that blood thinner for the treatment of the AVMs.
Okay. So the next question is, do you have any information about patients having long-term chronic pleurisy or pain after embolization?
I don't. I've never seen anything in the literature about that, and I've never had a patient that's had that. I think the longest I've ever had somebody have that was 2 weeks. And we tried, our initial treatment regimen is always just anti-inflammatories like ibuprofen, which you're really not supposed to take if they have nosebleeds. But, for pleurisy, we do recommend taking that anyway as a first line for the pain. If that doesn't control it, then we put them on steroids. And I've even in the 2-week situation, the reason he had it for 2 weeks is because we went for a longer period of time with the ibuprofen, and he was kind of doing okay, but he got to the point where it was just bothering him too much, and so we put him on steroids, and it resolved almost immediately. And then once he was off the steroid dose, which was a tapered dose of steroids, it didn't come back. And I've never had anybody have pain beyond the steroids, so I don't have any experience with that, and I've not seen anything published.
Okay.
It might be from another cause, and maybe there's something else causing that, potentially, I suppose.
Okay. So if they do have prolonged pleurisy or pain after embolization, that's definitely something they should consult their physician with.
Yeah, absolutely.
So can a patient actually feel recanalization or reperfusion just in their everyday life activities, or is that something you would only find through screening?
Yeah, you won't feel that. You'd have to be screened for it. And that's kind of outlines the importance of coming back for follow-up visits, because, even under the best of circumstances, by physicians who have had years and years of experience with treating these, we still occasionally get arteries and AVMs that recanalize, or have a new blood vessel that finds its way to that area, or what have you. So it does happen even under the best of circumstances. So follow-up is really important. And there's no sensation that people would get that it's open, unless, so one caveat, there's always an exception. If it's a really large AVM and it was successfully to the point where the patient was having exercise intolerance, maybe, a middle-aged individual or somebody that exercises a lot, and they notice they're having shortness of breath and not able to exercise, they discover an AVM, it gets successfully treated, and now they are able to exercise with no shortness of breath. And I've had this happen. I've had a patient with this exact scenario. It was a early 30s female that I actually worked with that was discovered to have HHT, and she was a runner. We treated her AVM, and the AVM, was occluded, and she was able to run. And she said, I had no idea how much that was affecting me, because she was able to run much farther distances, much faster, with much more stamina. So in that situation, it was a total success, and it's remained that way. But if she were all of a sudden to start having difficulty running and noticing shortness of breath, and in that situation, you would notice a clinical difference because it was so obvious on the front end. But in a patient who didn't really know they had AVMs to begin with, you probably wouldn't notice it. Once it had occluded and you didn't really notice any significant change, you might not notice that it's reopened again. So the follow-up really is important for a number of reasons.
Okay. So the next question is, what should women with complex AVMs that were treated a few years ago do if they're thinking about getting pregnant?
You definitely want to get, go to the follow-up study, or, go get a follow-up evaluation, or, if it's been a year or two since the last time you went, just check back and call your physician, preferably the physician that's taking care of you at the HHT Center where you're being cared for, and just let them know what your plans are and see if they feel like it's important for you to come back and have another evaluation, repeat the CT scan, repeat the bubble echo, whatever your circumstance is. It'd be a good idea to check, because if there's anything that was small and it's now grown, or was previously successfully treated, that you want to make sure that it's still occluded, you want to make sure about that on the front end before you get into the pregnancy situation, because things get more complicated. And I didn't go into the details of this, but during the first trimester, we can't treat patients. We don't treat patients because the organogenesis, the organs are developing in the fetus, and we don't want to expose that to radiation, expose the fetus to radiation during that period. So we wait till the second trimester when it's less prone to radiation problems, and we can treat the AVMs, and it's before the critical third trimester where the blood volume is increased to the point where there's a risk of rupture. So anyway, it's a long-winded answer to the question. Hopefully that answered it.
Okay. Is it important for patients to know what specific plug or coils were used during their embolizations?
type or size? I'm sorry, I missed one of those words.
Yes, what specific plug or coil was used during their embolization?
Yes. In all of our, whenever we discharge patients after a treatment, we always have, there are little stickers that come on each product that we put inside the patient, and the patient always gets a sheet of paper with those stickers attached, or at least a copy of it. The reason being is because mainly for subsequent MRIs, if you have to get an MRI for any reason, whether it's to evaluate cerebral AVMs or for some unrelated reason, you've been in a trauma and you need to get an MRI to evaluate, you know, for a bone fracture or what have you, you want to know what kind of metal is in you, and the people that are doing the MRI are going to ask you, do you have any devices in your body of any kind? And you want to be able to say, well, yes, I've got coils and plugs, and here's the list of what I've got. And then they can check to make sure that it's MRI compatible, which I can tell you everything that we put in patients now is MRI compatible because all of the products have been tailored such that we can put them in MRIs. But anyway, yes, it is important to have that information.
Okay, good. Let's see. Do you know what the frequency of misreading or misdiagnosing a CT scan for HHT lung AVMs is, especially, you know, outside of an HHT center?
It's going to be pretty small because that's something that all radiologists learn about during their training. So usually if a radiologist, even outside of an HHT center, sees an AVM on a CT chest, they're going to identify it as such. If they are really small, to the size that we probably wouldn't treat them, like the less than 2 millimeter size feeding artery, they may not necessarily recognize that as an AVM. So we're much more, you know, suspicious of patients when they come to us, so we notice those kind of things more. But essentially, those are probably, you know, not clinically significant, or at least significantly less significant. If they're big enough to be significant, almost all radiologists are going to call that.
Okay, and then just our last kind of question or statement for the night. Could you just re-clarify or restate the need for prophylactic antibiotics regarding lung AVMs, why that's important, and who should be using them?
It's basically with dental work. So if you're having dental work done, because our mouths have bacteria in them all the time and you can't sterilize it, when a dentist goes in there, they can't sterilize your mouth. And while they're poking around in there, there's, you know, anything that they do near the gum line is going to result in some irritation of the blood vessels, and the bacteria can get into those blood vessels from the mouth. And so that introduces the risk of infection, which introduces the risk of bacteria getting into the bloodstream, passing through the patent AVMs, or even, you know, treated AVMs to some degree, and resulting in a brain abscess. So those are the patients that antibiotics. That's why we put patients on antibiotics.
Okay. Well, and as everyone can see, I know there were some other questions. Unfortunately, we have even gone over our time a little bit here, so we couldn't get to all of them. But the real benefit of going to an HHT center, because they do see HHT on a regular basis, we don't have the misdiagnosis, and they are the most familiar with the most current treatment protocols for HHT. So on behalf of Pure HHT, I want to thank you for attending tonight's webinar. Our shared goal is to advance one common hope to give those affected by HHT a chance for a normal life. And our next webinar will be held on November 19th at 7 p.m. Eastern. We're excited to have Backpack Health share a live demo of all that this new app for HHT has to offer. If you didn't already know, through Cure HHT, this is a free app available for both Apple and Android products for the HHT community. All the information in the app can instantly be translated into 6 languages. You can manage your entire family in one place. You can store images and medical records and so much more. So mark your calendar for November 19th at 7 p.m. Eastern. Registration will begin tomorrow. And this webinar series is just one of many ways we accomplish our mission. We're grateful to the doctors and donors of Cure HHT for making this happen and all of the webinars possible. Please consider donating to Cure HHT to ensure we can continue to offer high-quality education for you and your families. After the webinar, you will receive a short survey. Please take a few minutes to answer these questions so we can serve you better in the future. And again, I want to thank Dr. Riggans for volunteering his time tonight to lead this webinar, which has been recorded and will be posted on our website at www.curehht.org in the resource library. We truly appreciate your participation. Enjoy the rest of your evening.